טוב, close my...
Wow, I see more and more people. Okay, we will start in a minute because I see that more are joining us.
Linda, how are you?
I'm good. I have a new heart.
Mazal tov. You feel okay?
Yeah. Just got home.
I see you here. I'm sorry, you just go home?
They did the surgery was a week ago, and then on Friday I had to have a pacemaker, and on Saturday I came home. So yeah, I'm good.
You look great.
Thank you.
Yes.
I'm just finishing my dinner, so I'm going to go off video for a few minutes.
You do what you need to do. Paulina, Heidi. Hi, Heidi.
Hi. Okay, so we will begin, and I'm recording, so if anyone will miss the beginning, you will be able to see it later. So hello, everyone. I'm really happy to see you. And tonight, really, it marks a significant milestone for Planetherapy. And I'm deeply honored to introduce and welcome Professor Avi Peled to our advisory team. And before we begin, I want just to take a moment to personally thank you, Muli. For those of you who may not know, Muli is a key member of our organizational advisory board and has been guiding us behind the scenes. And this vital connection and our partnership with Avi were made possible thanks to your support, Muli, your vision, and we're grateful for that. So, Muli, would you like to say a few words before we start?
First of all, I want to say that I'm the one that is grateful for all of you here, that I see some of you for the first time, some of you I already know from the visit in Israel. And I can tell you that every time I hear from a patient of yours that is using this platform, telling me how amazing it is, it's just heartwarming to hear it over and over again, and it's really amazing how it is growing. And I want to tell you, Avi, which is one of the leading psychiatrists in Israel, I'm working with Avi for the last few months on a business project. And when he heard about Planetherapy, the first thing he said, listen, I can contribute. How can I join? And it is really an honor to have you a part of our advisory board here. And Avi, the stage is yours.
Thank you very much. Okay, so we start. Can you hear me well? Yeah, okay.
Very well.
For some reason, I don't know why, but when I do share, it opens a window.
I can share your screen, with the presentation.
Okay, so let's try it, because here it does not...
And before you begin, I just want to say a few words about you, Avi, even though I wrote it in the invitation. Professor Peled is a senior psychiatric with over 30 years of clinical experience. He is a leading expert in neuromodulation and the integration of artificial intelligence in psychiatry, known for his unique expertise in treating complex psychiatric conditions. And as we said, Avi has generously agreed to lead this essential training, and for us, more importantly, to serve as our professional psychiatric consultant moving forward. We have later, after Avi will finish, I will share. We have about 30-40 minutes and then we will have time for questions. And I will share one page that presents a slide summarizing our current resources and answer organizational questions as long as there are. And okay, so now, Avi, we can begin. I'll just share my screen. Let's see. Okay, let me know if you can see it now.
Oh, great. Okay. Okay, they always ask me what is the specialty of a psychiatrist, and I always say there is some truth in it, that the specialty of a psychiatrist is to confuse himself and others, because there is a lot of confusion in psychiatry. And in this talk, I will try to a little bit to clear some of the confusions that we have regarding diagnosis and illness. And then I will just give an example of how structured diagnostic approach can help in tough situations, and especially as a consultant in situations that you would need or want to share with me, because mainly because of medical legal responsibilities, like in emergency cases. But before that, I want to make clear some of the things that we know about diagnosis in psychiatry, but most psychiatrists don't want to admit it. So we'll start with the DSM story, and then we'll take a peek into the future, just 1 second. And then we'll talk a little bit about disease and diagnosis in psychiatry and in medicine. And then we'll talk a little bit about structural approach to risk. Okay, so we can go ahead with the next slide. Can you, I cannot control it from here, can you? Oh, okay. So let's take a clinical condition, typical in psychiatry. The patient comes to the psychiatrist and he says, "Doctor, I'm sad, I'm depressed, what do I have?" The psychiatrist will tell him, "You have depression." The intelligent patient will think to himself, "I just told you that. What added value can you give me?" Next slide. You'd expect, like, you come to your family practitioner or whatever, and you have a stomachache, that he will do some kind of procedure and come up with a diagnosis like, let's say, appendicitis or something like that. Appendix is a location in the body, and the ending, itis, is for infection. So you have a location in the body, and you have the cause of the disorder, and this is called etiology. In psychiatry, when you say depression, it's not a location in the body, linguistically, and it's not any kind of mechanism. So this is actually a very strong fact that shares all psychiatric diagnoses. There is no etiology. We don't know what's causing the disease. So we are left with a description. And depression is a description. What kind of description? It's like what the patient says, the complaints, that would be the symptoms, and observation of the clinician. So it's just a description of signs and symptoms. Symptoms are the complaints, signs are the observation. And we didn't really advance from 1600 till today in that aspect. The first diagnostic entities were very few: dementia, mania, idiocy, melancholia. In France, Pinel was the first psychiatrist. He said that the psychiatric patients are sick, and that's how he invented psychiatry in one moment. And everyone will tell you that Pinel was the first psychiatrist, but if you know the history, then it's not true. There was an Italian before him, Chirurgi, and he also wrote a book with diagnostic entities. And as you can see, in Italy, there is no idiocy, only in France. So I don't know what to make of it. The French have idiocy and Italians don't. I don't know how to explain it. And this aspect of diagnosis, descriptive diagnosis, comes even today. But how did it develop? Next slide. People just describe the patient. So let's say in Berlin, there was this guy who described the patients in many ways, like catatonic, dementia, and so on. They have these names. And not far away from that, in Switzerland, there was this other psychiatrist called Bleuler who gave the name schizophrenia to a bunch of patients and described them. We won't go into it, but there was a description, famous 4A's, that you diagnose on the patient. And so there was already a big confusion. If you are a resident in Berlin, you will not know what schizophrenia is, and you will probably diagnose dementia precox or something like that. But if you are a resident in Switzerland, you don't know what dementia is, you know what schizophrenia is, and there is a lot of confusion. And in order for the confusion to become even worse, there was in Vienna this guy, Sigmund Freud, and he talked different language. Instead of describing the patient or trying to find the causes of the disorder like Bleuler tried, he had an etiology. He thought that he knows what's the cause of the disorders, and they were weakness of ego and impulses and interplay between theoretical constructs which probably occur in the brain, but the brain name doesn't exist, actually. And also these other psychiatrists, they didn't use the term brain in any of the diagnoses. So even though everyone agrees that the brain is important for mental disorders, it's not even mentioned. Now, what happens then is becoming very exciting, and it explains where we are today. So we are learning this historical perspective in order to understand what's happening today. So Bleuler and Freud, they were invited to come to America and give a talk. And it's a story in itself. Freud did not want to go, then he wanted to go, and they gave him, they paid him, and he came. So there is a story behind that. But once you come to America, what is characteristic of America at that time, or maybe even today, that in America they like celebs. So Freud became a celeb. And what does it mean? It meant that the American psychiatry became psychodynamic. So what does that mean? That means that when you diagnose a patient and you present a patient in the emergency room or in the department or whatever, you present a patient that suffers from weak ego, strong id energy, and disturbance from defense mechanisms. This is the language that you will use when you present a diagnosis of a patient. While in Europe, they stick to the description. So you will describe the patient as depressed because he looks depressed and he has dementia precox, that is deficiency syndrome. You stick to the description and you don't use any assumption or theoretical idea about the patient because you acknowledge the fact that we don't know actually. So this was in the 20s, 30s, 40s, 50s, 60s, 70s. Until the 70s, the American psychiatry was very psychodynamic. Now in the 70s, late 70s, beginning of 80s, there is something very exciting happened in the United States that influenced us until today. And the next slide. There were two studies that came. One was called US-UK. They took video films of patients. They recorded the patients. And the spectrum of patients was the entire spectrum. There was schizophrenia, mood disorders, and other disorders. And they split the videos, they copied them, and they gave them to diagnose to American psychiatrists and British psychiatrists. And what happened is that the American psychiatrists diagnosed 80% schizophrenia and 20% other disorders. And on the same sample, in Europe or in England, they diagnosed only 20% schizophrenia and 80% others. The bottom line of this paper was that when a psychiatrist from America talks with a psychiatrist in England about schizophrenia, they surely do not talk about the same thing, and who knows what they know about it. Okay, next slide. At the same time, when this happened, and you have to understand, in America, the medical system is private. Who pays for the diagnosis, for the treatment? Insurance companies. Now, the insurance companies, they read this article, which came in a good journal, and they said to themselves, what am I paying for? Here is it was published in a good journal that says that American psychiatrists and English my psychiatrists don't know what they're doing. But let's say that they were still tolerant. So at the same time, I think 3 years later or before, this guy, Rosenhan, he did the famous Rosenhan experiment. He was a social worker, he wasn't a psychiatrist. And the experiment was sending people to emergency rooms all over the country, to emergency rooms, and telling them to complain that they're hearing voices. And that's it, they're faking the voices. And he told them, don't worry, psychiatrists are professionals. You're faking it, so they will probably diagnose that, and nothing will happen to you. But if for any reason they will hospitalize you, then you stop complaining about the voices and you act naturally. All of them were diagnosed schizophrenia, all of them were admitted, all of them got medication, and all of them got released after having a remission, schizophrenia remission diagnosis. And when he started publishing the results, there was a university, I don't know which one, but there was one university who said, university hospital that said, it won't happen to us. So he said, okay, I'll do opposite experiment with you. I will send you fake patients, pseudo patients, they call them, and you in the emergency room, you have to diagnose which ones are patients, fake patients, okay? They came up with, I think, something like 14 fake patients when he didn't even send them one. The bottom line of this paper that came out, the paper was called Being Sane in Insane Places. And it came out, and the bottom line was that psychiatrists don't know how to diagnose a healthy from a patient from healthy. Now, the insurance companies were really upset, and they really didn't want to pay. And people who remember that time, I spoke with someone from that time, and he said that they cut payment for psychiatrists, closed the departments, and it really influenced the condition of the psychiatrists. Some of them even lost their jobs because of that. And also the position of the psychiatrist within the department, in the department of psychiatry, who is the chair of the department? It is not the psychologist, it's not the social worker, it's typically the psychiatrist. And from personal story, I heard that in the hospital where I did my postdoc in Napa, the social worker came in the morning to the meeting, and he said, why should you be the chair of the department? Here, we know even better than you. Here is a proof that you don't know how to diagnose patients. So there was really a panic, and this caused, there was urgent need for inter-rater reliability, at least as emergency. So next slide. And there was a lot of criticism that psychiatry is not medicine. There was even a story about one university that wanted to take psychiatry out of the curriculum of medicine. Next slide. So these two people, one of them is still alive today. He even gave a lecture here in Israel once, Alan Frances, and the other one is not with us anymore. But these two people in the 80s, they took the DSM, which was a book with numbers for insurance companies, and they added the descriptions, and they changed the name, and they called it DSM, Diagnostic Statistical Manual. Diagnostic is the criteria, which are descriptions. Statistical, I didn't see any statistics in that book, and manual, it could be a manual. And they took the criteria mostly from research. There was a booklet called Research Diagnostic Criteria, and there were lists of signs and symptoms for researchers to choose patients for study. And And this is how the DSM came about. And they immediately started marketing it as if it was real medicine and as if it was real disease. Okay, but very quickly, things began to seem wrong. Next slide. Next slide, okay. And first of all, the DSM grew from a booklet to a book in an unnatural way. This is not how medical disease develop. Next slide. Then came the issue with the homosexuality. In DSM-3, the homosexuality was a disorder, and in DSM-4, it wasn't. And this happened because of political pressure, and the psychiatrists met up in a meeting, and they voted, and they said, who thinks that homosexuality should be eliminated from, it's not a disease, raise his hand, and this is how this disease became non-disease. And just imagine physicians meeting in a congress and coming together and say, who thinks pneumonia is not the illness? Raise his hand, no pneumonia. So these things revealed how fiction is the diagnostic system. Next slide. And in 2013, when they came to do the last book, the DSM-5, then this guy, Tom Insel, he was the head of the NIMH, meaning that he is the person that decides what will be science and what will be everything. And he said, DSM is not valid. It can be inter-rater reliability, but you cannot validate it because there is nothing to validate. You validate if you have appendicitis, if you have infection, if you have something that you can validate, but the description is not, you cannot validate. And also they realized in the committee that there were no categories, actually, there is spectrum, patients come with spectrum of symptoms, that there is no etiology, that pharmacology is not according to the DSM, because, for example, SSRIs are effective for depression and for anxiety. So different disorders, the same pharmacology. And the most striking thing that they described is that instead of helping us find the etiology, actually it hampers, impedes the development of science. And all the research was done according to the DSM. So if the DSM is false, all this research is also false. And we are actually today, next slide. We are actually today left in this condition. And the problem is that many psychiatrists, and we teach residents and we teach medical students, and we think ourselves sometimes that the DSM is real, but it's not. So this is something that many psychiatrists don't want to acknowledge, but it should be. When you diagnose your patients according to the DSM, you should know how it came about and what's behind it. Now, in order to, no, let's keep the previous one. Let's go a little bit to the history and see something that is related to history, but is the future, which is very interesting. This handwriting, you know who is it? Who wrote this? Someone wants to guess? I don't hear anyone.
Is it Freud?
Yeah, it's Freud. Okay, let's go to the next slide. This was written by Freud in letters to William Fliess, a friend of his from Berlin. And in the correspondence, they tried to show how the brain actually works. What you see are signs of the brain. Let's go to the next slide. And they were influenced by the chair of department of Sigmund Freud at that time, who was Theodor Meinert, and he looked in the microscope. It was the beginning of coloring the neurons, and he saw these networks, and he said that these networks are actually developing according to the experience that the patient has. And because each experience is different from each other, then each of the networks is personalized for the patient. And he looked for a name to give this network brain organization, and he called it ego, ich, which means for the self. Like so the term ego is actually a term that describes a neural network in the brain at rest. Today, we know there is a default mode network, which is actually a description exactly like that Maynard described. But he used the term ego for it, and Sigmund Freud was his student, and he agreed with him. Let's go to the next slide.
Mama, I love you.
So as you can see, these round objects here are the neurons, and these boundaries between them are synapses. And actually, Freud and Fliess and Maynard actually were the fathers of what we call today computational neuroscience. And below, you can see architectures of simulations of the brain. Networks could be fully connected or connected in layers. Next slide. And in 2024, the Nobel Prize for Physics was given to these two people. One of them is Hopfield with a totally connected network, and the other one is Hinton with a layered structure network. And as you can see, both architectures actually exist in the brain, and you can see them actually in preparates of the brain. And they actually simulated the architecture of the brain. And why did they get the Nobel Prize now? Because of AI. Because AI is actually built on these architectures and the dynamics of these structures. So the AI became so popular, so they got the Nobel Prize. Next slide. Okay, I hope I'm still on time. One of the problems for you as clinicians and for us is to identify when do we need to intervene and when do we need to treat and when not to treat. Now, there is a big difference between the medical model and non-medical model. The medical model, you actually need to have a diagnosis and you treat it. If you don't have, then you don't need treatment. In non-medical models, like sometimes happens in psychotherapy or psychology, I often find the professionals say, everyone can benefit from psychotherapy, meaning there is not actually any decision for the clinician to make between treat or not treat. A psychologist will rarely say, oh, you don't need any treatment, go home, you're fine. Okay, because of the difference of the model. And the boundary between disease and health in medicine is pretty clear because typically disease is absence of health. But in psychiatry, in other fields of medicine also, but in psychiatry especially, sometimes it's a problem. And when you decide, when in your clinical practice, you can be aware of the medical model. Let's go to the next slide. So, for example, if you have psychosis or schizophrenia, the boundary between normal and disease is pretty clear. And also in mood disorders, it could be pretty clear. But where does this problem of deciding whether to treat or not to treat, whether it's an illness or not, important? When we have, for example, a differential diagnosis between personality disorder and personality traits. In traits, it's not an illness, and disorder, it is an illness. So the question, is this person needs therapy or not, is becoming important. Let's go, okay. So in psychiatry, we have something that other doctors don't have. We have the problem of having to understand what disease is. Regular doctors don't really go into this philosophical aspect. It's not important for the everyday practice. But in psychiatry, it's sometimes critical to decide whether to treat or not to treat the patient. Okay, so if we try to analyze what disease is, we can go linguistically. Linguistically, disease means this is meaning suffering. This is suffering. But if you have high blood pressure, it's a disease, but you don't suffer. It's not causing any pain. So the definition is not good enough. But if you want to include high blood pressure as a disease, maybe you should add to the description a statistical deviation. And many times you don't have statistical deviation and you don't have suffering, but you have some kind of function disturbance. Is that good enough? So what you get from this description here is that disease is a complex entity that cannot be defined just by one definition. It has to have a few definitions, but for you as a clinician, you have to extract from these definitions a guiding lines for how to treat and when to treat. Next slide. So what we typically, as clinicians which are in the medical model, we typically use this schematic approach where in order to decide if something is a disease or not, you have to have suffering, which is a problem because suffering is not the same everywhere. It's also culturally dependent. There are some countries where you go to the doctor because you suffer from something, and in other countries you don't. Because the suffering is not, you cannot really measure it. Typically, we look at it as if it causes the patient to come to the doctor. So if the patient comes to a psychiatrist, especially in certain countries where it's not really something that you want to go to a psychiatrist, but if you come to a psychiatrist, it means that your suffering has reached a level that caused you to come to a psychiatrist. And this is not enough, you also need dysfunction. Dysfunction is typically divided into love and work, meaning work being able to hold a job and function in a working environment, and love means in the interpersonal relationships that you have with a spouse or friends that is maintained optimally. So in order to decide that something is a disease, you need to have all of these criteria. Next slide. So now, if you want to diagnose between personality disorder and personality traits, you know how to do it. You have, for example, let's say someone is very sensitive to being tidy and organized and so on. And you mess the room up and you move things around, and he gets annoyed because he has, let's say, obsessive personality traits. Okay, but being annoyed or being angry about it is one thing. Or if it mounts to a level of depression or agitation or anxiety that causes you to suffer enough to come to the psychiatrist and suffer, and you have a dysfunction because of it, then you move from the traits to the disorder. So the disorder, we have to have these criteria, and this way you can decide if it's traits or disorder, and based on that, you can decide if to treat or not to treat. This is the medical model. I know that it is not always how other fields function, but the medical model is like that. Okay, how much time do I have left? I didn't take notice, but we're coming to the end. Okay, so we talked a little bit about the diagnosis in psychiatry. We tried to clarify a little bit the history. We tried to define what is a disease, not a disease in medicine and in the non-medical model, and when to treat or not to treat. And all of this is oriented towards, in your practice, to see if it can help you orient or have the coordinates in your mind when you are diagnosing and treating patients. Now, the last topic that I want to go into is how we approach an emergency where the medical legal aspect is very, very strong. And in this I can help because once you have a patient, let's say, that wants to commit suicide, the first thing that you would want to is to send this patient to a psychiatrist or to someone who can take the medical legal responsibility. And I hope I can help you with that, but I want to show you how we as psychiatrists approach this assessment and treatment of risk patients. And what I'm what I will do if you refer to me a patient that wants to commit suicide, and if you know this table, then you can actually do it yourself and assess to what extent is the risk. Now, the risk is very general assessment. It's like low risk, intermediate risk, and high risk. There is no higher spectrum than that. And what you have to have in your mind is this table when you have a patient like that who has it's like in medicine. You have a patient that are in an accident and you run to help him. Then you hold in your head A, B, C, airway, breathing, circulation. You have this format what you are going to assess. And also in psychiatry, you have this table here. So the table is divided into 4 axes. One is social, the other one is medical, the other one is psychiatric, and then you have an axis which relates to the event itself. Now, the first one, the social one, comes from statistical work of social workers. Typically, it was found that males have a higher risk than women, age 45 and more, unemployment, immigration status. In Israel, you have Ole Hadash, immigration, and in the urban living, and if there is no support, is not married, there's no family. All these are social workers have done these studies and found that they are higher risk. So let's say you approach the patient. If he's a male, immediately he gets a little bit of account that is at risk more than a woman. Okay, so just even before you started talking with him, you know that he is at a higher risk. Okay, if he's unemployed, increases the risk. If he's married, reduces the risk. So it's like stakeholders. You count the plus and minus, and you get an impression of this axis if it's a high risk or not. Durkheim is a type of altruistic suicide attempt, which is related to, for example, jihad or kamikaze. So this is related to some social specific aspects and less important for the clinic. Then if he has a medical issue, now if he has cancer, this increases a lot the risk. If he has a chronic disease, also increases. If he has a disease with pain or depression caused by hypothyroidism or pancreatic cancer, that increases the risk a lot. Neurological disorders increase the risk. There are specific studies that show that. Dementia, CVA, and epilepsy, neurological disorders also increase, but less, okay, than the other ones. So it's bottom down is the less or more risk. So now you add this on. So let's say you have a male, increase the risk. He has cancer, increase the risk. He's married, reduce the risk. So you're beginning to assess all these aspects. Now, if he has also a psychiatric disorder, so if he has depression, it's the highest risk, naturally. And schizophrenia is the second highest risk, okay? And you have to know in depression, the risk increases when he is beginning to improve, because then he's still depressed, but he has the energy and the motor activity to commit suicide. And in schizophrenia is when they realize they have deficiency symptoms, that's when they commit suicide. So they have specific periods where they commit suicide. Alcohol use, substance use, personality disorders, and untreated anxiety and genetic predisposition, they are all less, but still add to the risk. So now if you assess the patient, let's say he's male, increase. He has cancer, increase. He has depression, even more. Okay, but if he's, let's say, married, then less, or he doesn't have cancer, then less, and so on. So at this stage, you pretty much have the background of whether it's high risk or intermediate and so on. Now you typically see the patient after he committed suicide. If he committed suicide, you don't see the patient. So you typically have the history that you can take that involves before, during, and after the attempt. So if before the attempt he had repeated thoughts about it, repeated attempts, or a concrete plan, increases the risk than if it was impulsive, okay, compared to impulsive one. And the attempt itself, if he, for example, took pills and the house was closed, the family went away for a vacation, no one will be looking for him, it's one thing. Or if he takes the pills in the house when the other family members are there, and they hear the noise of the pills container opening and closing, or when they do it just 5 minutes before the husband comes from work, then it's a different thing. It's more like a cry for help. So it reduces the risk, at least if the situation is contained, then it can reduce the risk. But if it's deterministic, then the way that it is done is important to assess here, to understand if it's cry for help or not. And after the case, there is attitude towards what he did, the suicide attempt. If it is remorse, then it reduces the risk. If it's apathy and at least also philosophical approach to what life is and so on, then it increases the risk. So now you have this last axis here, before, after, and during, that it can help you collect all the. Now you collect all of these items and you decide if most of them are at high risk, then it's high risk. If they don't exist, most of them, or there is protection like being married and working and so on, then it reduces. But at the end, you have to decide whether it's low, intermediate, or high risk. And according to that, you have to act. And all this has also a very strong medical legal requirement, because if you write it correctly and count all the items and explain them and then show how you reached your assumption, then you're pretty much, you can defend yourself. I mean, in these cases, in Israel, in America also, you have to think as if you are in court and you are being investigated for what you did and to see if you were professional enough or not. So this is something to know and to hold in your mind when you go to see this kind of patient, or immediately when the patient tells you something about wanting to end his life, then you have to assess all this.
So
very similar.
Avi, do you mean that if we have someone that tells us that he wants to end his life, does it mean that when we write the email to you and we ask for your opinion or your support, do you want us to write, according to this slide, a bit about the person?
I want you to know it, because what I will do, I will actually ask you. So if you tell me, look, this patient, I have this patient that he said he wants to end his life, or he said he tried to commit suicide in the past or even recently, then I don't expect you to do it. It is my job. This is what I will do. I just want you to know what I'm going to do. So I will probably ask you, is he married? Is he an immigrant? Does he have any medical illness? Does he have any psychiatric history? I will ask you about these items. And if you know them ahead of time, then we can save a little bit of time instead of going forth and back. You can tell me, look, I have this patient and he has this and this and this and this, and then we assume that he has a high risk, okay?
Yes.
Or we say, okay, he has a low risk, but let's see how it goes and so on.
I have a question.
I just want to say that if you have a call with someone who express suicide ideation and you feel that they are in danger, the immediate thing you need to do is to call 911 or have them call 911 and stay on the line with them if it's this level of risk. And then, of course, reach out to Avi and to us. But if you feel like the caller is in immediate danger, make sure that you reach to the police.
Okay, so this is why I'm doing this lecture. I don't feel. The word feel is not what I do. I feel because I follow these criteria. So I have sound criteria in order to, even when I call the police or even when I call the ambulance or whatever, I can tell them, look, this person is 1, 2, 3, 4, 5, and because of that, it's high. And I will decide if to call the police or not based on that, okay? And in the registry, you write that you did what you did, and this is supposed to protect you if you decided not to, let's say, okay? But
Avi, is it not right to say that to be on the safe side, anytime someone is telling you, I want to kill, I'm going to kill myself, to call 911 or just to be on the safe side?
To be on the safe side, that will be that even anyone that will just talk a little bit about suicide or tell you about committing suicide, then you automatically refer him. You can do that. But then it sounds like this. Oh, this guy told me that he wants to commit suicide. I don't know what to do. I'm afraid. I'm helpless. I'm hopeless. I'm not professional enough. And I want to take this hot potato from me and deal with it, you. But
I have a question.
I'm talking about the person who is on the other side, who needs to decide. So you understand, it's more professional based if you know what is the risk and you say you can discuss it. Otherwise, it will be and there are patients who take advantage of that. They know it. They will tell you things in order for you to become stressed or interested in them more in psychotherapy situations or things like that.
I see
okay.
Igor and Ilana they also have questions. Igor?
Yes, if it's just a matter of looking at the criteria and asking questions and seeing the answers, seems like a machine could do that. So what is the specifics, your human specifics as a doctor that is different from a machine?
You cannot take a machine to court and sue him. That's right. The difference. That will be the difference. No, I'm talking about something that I have experienced for many years. I actually got these phone calls every time that I did a night shift or I was responsible for the residents or whatever. And I get it from psychologists and psychotherapists. The moment so the only thing I want, I don't expect much. I expect that you know what I'm going to do and what I'm going to base my decision on when I respond to something like that. So they call me, that's what happens typically, or the psychologist comes and says, this patient told me this and that, I don't know what to do. Do I have to, like Muli said, do I have to report him anyway? Then to decide if to report or not, and based on what, and when you present it to your colleague or to the police or to the emergency room, if you base it on something like this, then it's professional, it's more accurate, it's more focused, and you're likely to make less mistakes. I'm not expecting that you as a psychologist or resident that is not professional yet or is not didn't pass his exams yet, he naturally transfers it to me but I'm the last resort. I'm the one who decides and has to take the responsibility. And I just tell you here, how do I base it? I base it on that. I'm supposed to be okay, anything that happens, if I do everything correctly here, okay? It's not going to be very nice experience to go to court and being accused or investigated if someone did commit suicide. And I had cases like that in the past, where someone I assessed and they said that he will commit suicide, he did commit suicide or not. So
okay. Is it okay that we continue with the questions? Because I see...
Yeah, because I have only one more slide, which was about homicide, which is very different, very similar to that. but you can just the same, very similar criteria. And then there is also the malingering patient, which you might encounter, and it could be interesting for you to know how to diagnose. If you have a patient that there is a lawyer in the background, or lawsuit, or something has to do with the court, then better tell him, finish your business with the court and then come to me. Because many times they manipulate you and the lawyers tell them what to do, what to say, and how to manipulate you in order for them to get what they want, a secondary gain or money or some kind of. So malingering is also something that you can actually be aware of and beware of. Okay, so questions.
I see Ilana and then Michal and Muriel. This is what I see.
Hi, very quick. I'm not going to take your time. Thank you so much, first of all. I wanted to say that when a person calls and threatening to commit suicide, because we are in different countries, we cannot call the police, because it's happened to me personally, and a person was screaming to me on the phone, I'm going to do it, I'm going to do it now. And I had to hold her on the line and call the police, and police said to me, of course, normally if it happens in your country, that's the number one, you have to by law inform the police. But when it's in a different country, it's a different matter. And so, first of all, it's amazing that you're here. I personally got, Tal was there, remember? I got messages exactly at the criteria in your first slides. Everything as what you mentioned, single, very mystical messages, all talk about suicide. I couldn't get any information. It was all happening through Planetherapy social media. So just keeping him online, keeping him to talk, asking him questions, giving him little tasks to try and pull the time until I get someone in Israel to find him. They found him. They called the police and then he disappeared again. So it's really helpful that you're here, because I really believe that it would help us to do it even more accurate. So I really appreciate it.
Okay, in Israel I can help a lot, also by advice and also by practical things. Because in Israel, if you call the police, they say, I don't have insurance for this, to take this guy. I'm not, it's your problem. That's what they will answer you, typically. So in Israel, we have a system which is pretty effective. We have north, south, and middle countries divided into 3 districts: North District, South District, Middle District. And each district has a on-call psychiatrist who can send an ambulance with nurses which come to your house and they take you even against your will, but they don't take you for hospitalization, they take you to a psychiatrist in the emergency room. And then he gets to the psychiatrist in the emergency room, and that's his problem from that moment on, okay? And I can help with that because I can also help the psychiatrist in the emergency room decide. And if I send him or give him a report like that, it makes it very easy for him to decide and to take responsibility. So the whole process can become more smoother, although it's always traumatic. This is Israel. In the US, there are different laws in different states. I was in California, and there the law is very, very, very let's say, positive for psychiatrists, because psychiatrists want to have the possibility to hospitalize someone against his will. And in Israel, there is a lot of sensitivity to liberty, to personal liberty, and the law makes it very hard to hospitalize anyone. They only allow you to hospitalize someone if he's psychotic, which means he's hallucinating and so on, and if he's going to commit it immediately. He's holding the knife or he's holding the gun already. Only in that condition you can hospitalize him, which is very tough because it doesn't give us the power to protect the patient. In California, I was very happy to see that you can hospitalize someone for 48 hours even if you're a policeman. You can do it, and then there is a judge and the consultant that comes and decides if they continue or not. After 48 hours. In Israel, after a few hours, like 7 hours or less, you have to have a committee immediately. So it's very hard to commit someone in Israel. In Israel, a false negative is not allowed like in the States. And in the States, it's easier in many places. So I don't know. In Israel, you will not call I will not suggest to call a police. The police will not help you. They don't even want to take a patient from one hospital to another if they need to. You need to have a special ambulance.
It was in order to make sure that he's okay. That's why they were afraid. But yeah, but it's good though. It's good to have you so we can have more.
You can call me and we'll discuss the case, but just know that I myself, I don't have any magical powers. I work according to this kind of schematic, important way to, the importance is to extract the information and understand what's behind it. Sometimes they expect the psychiatrist to have some kind of power, but they call me to the emergency room because someone was breaking the windows and the whole emergency room. And they call me and they say, come quick, he's destroying the emergency room. And I tell them, what do you think, that I will come and will stop doing it? And call first the police or the guardians to hold him, and then I will come. So just an example of something that there is always an expectation that the psychiatrist has.
We still have that expectations, just for you to know that. Okay, we have a few more minutes. So Michal and Muriel.
Hi. So I just want to clarify and understand if I'm not talking about emergencies, like someone is threatening to commit suicide as we talk. But if I speak to someone and I get the impression they are contemplating suicide, then I need to contact you to confer on the case, and then we'll decide where to refer this person, because we are, again, in different countries. I don't know where the client will be, so there's a jurisdiction issue. But just to understand the process, that's what we are expected to do.
Look, we are not in an institute that we have protocols and roles and things like that. You can consult with me. Then I can say what I think. Then I make sure that you write it correctly. And then in the letter, in the registry, you write that you consulted with a senior psychiatrist and so on, specialist. And this can help you in some sense. I don't know abroad how it is. In Israel, it can help you a lot because...
I'm in Canada, so it's very regulated here. So that's why I'm asking.
So now after you'll tell me about the patient, we decide if he is at high risk, then we can investigate, you'll investigate what is the law in Canada, specifically in your place, and we'll see how we can comply with the law. So you won't make any mistakes and they will not sue you.
Okay, thanks.
Muriel?
Yeah, I have a question regarding what Ilana said. If I'm based in the UK, I'm seeing someone I don't know in the US. This client, usually we don't have a note like my normal practice, like I have their address, and I always have someone in case of emergency that I can call. So that before I go to the police or before I call maybe a psychiatrist, or maybe if I feel that person is about to do something, say, well, I'm going to call you or that person on my file, but we don't have that at Planetherapy. And I wonder about I don't have the address, I don't know where they are, and I don't have that person name and number that I can call in case of emergency. And I was wondering whether that's something that you would recommend that we do.
So you don't have the demographics, age?
I don't know, but we are not having information about the patient. We don't. I don't have a number to call. My private practice I do, but not for Planetherapy. Mm-hmm. You know what I mean? So I was wondering whether that's a case to get someone in case of emergency, even if the person is not suicidal. Let's say I'm speaking to them and they have a heart attack. What do? I cannot call anyone to say, hey, we have an emergency.
So in Canada, if someone has a heart attack, he is just dying like this at home or on the street. You don't have emergency to call.
You know, if I speak to someone via Zoom and that person, I feel, I mean, there is a case here for asking patients for a name and a number, just in case.
I will just say that we do ask for a city, not the specific address, but we have the city, and we also have their phone number and their email address.
Yes.
And if I agree, we don't share the phone numbers, but if you think that there is something, listen, we're talking about really, you know,
extreme cases, yes.
Really few cases, and we have the numbers, okay, for these cases.
Right. Like, do you have the number of someone else to call in case of?
No, only for the patient. No, only for them.
Okay.
So what we actually working now on how to fine-tuning the protocols exactly for that. And one of the things that we may do, and this is something that it's work in progress, and we will have the protocol in the next, within days. Is there all the clinician, all the practitioners on our platform will have a few phone numbers that they can reach either in the US, in Europe, in Australia, in Israel, and there will be a person on call that have access to the database of the clients. And then once you alert us, we will be your hotline, you call us, we find the person information, and we take it from there. Or each clinician, each provider will have the database of their own callers. So in case of emergency, you will be able to do that. So we are working on this and considering all the legal consideration and confidentiality and also other relevant consideration.
Thank you.
So what takeaway I want you to have is, first of all, what is the psychiatric diagnosis? Today it's not real diagnosis, okay? How it can complicate your work once you decide, because you decide according to the diagnosis, you decide how to treat. And the boundaries that we have in medical models and not always they exist in other models. And this case of, and a little bit about the future, which is very interesting. Computational neuroscience will probably what Maynard said will be the future. We already have networks in the brain that we can use to diagnose. And we are at the brink of being able to, because once you have a network that is disturbed, then you have a location in the body that will be the cortex, and what happened to it. So it's real medicine. Maynard, the term ego, a disturbance to a network is the future, actually. So Freud disconnected it from the brain. He said ego is a theoretical construct. It's a big mistake, okay? It will be shown in the future. And also psychotherapy is something real, because when you talk to the patient, you change the connections in his brain and you change the network. So you're actually there is no biology, psychology here. It will be united. When you do psychotherapy, it's called experience-dependent plasticity. The patient has this experience with you once a week, and the plasticity-dependent means that the changes in the brain, in the way he thinks and perceives himself and others, and also is changing according to the experience. So it doesn't rule out and say psychology is not, it will all unite in the future. So I want you to understand this, and if you read the literature, you will see that it's going this direction. And hopefully we can contribute to that with Muli when we develop some kind of functional imaging. And then the last thing is just something that I know that you will need. And once you call me, then half of the burden is already transformed to me. Only the fact that you can say that you consulted. In Israel, I can take the responsibility. If you say that you consulted with me, that's it. You are free. In other countries, we'll have to see the interface with the law. How does it work?
Thank you, Avi. We're truly grateful, really. I do want to take 2 more minutes just to share. Can you see my screen?
Yes, I can
Yes.
see.
So, okay, how do I present? Okay, so here we added you, Avi, and we have few professional support resources. I think many of you already met Jim. He's a psychology from Haifa, from Israel. And if you have anything, you can reach out, you can ask him. We also have regional group supervision. We have Einat, Karen, and Hila. And I think they have a group once a month or bi-weekly. Hila is in Hebrew and in English. And we have also personalized one-on-one supervision. And you can just go to our therapist in the website, and then you can just need to look for supervision, and you will be able to see all of our therapists that provide the supervision, and you can book a session with them. So feel free to use those resources, and hopefully they will be able to support. So, and we also have a file in the website of numbers for in each country, most of them in Israel. So that is it. Rivka, I see you have also questions or something. Hi, Rivka.
Sorry. Yes. Can I also book the psychiatrist in the same way on your website?
No, Avi, do you want to share how you want us to reach out to you? But if I understand right, is via email. You said that you are...
Email is best. I don't know, you use WhatsApp?
Yeah, WhatsApp as well, yes.
So yeah, I can give you my number. You can call me.
Thank you, because I have a specific question and it's not going to take long, but I need to check, and the client is in Israel.
No problem.
Thank you.
Israel is our territory.
Okay, so we will send an email later with the record, and then with Avi's email and phone number for WhatsApp.
Okay. I'm used to it. You can call me, no problem.
Thank you.
Thank you very much.
So we're almost did it in 1 hour. But for those of you who want to stay to ask questions, we are staying here, Ilana and me and Ruti. And if you want to go, it's also feel free. It was very good to see you all, and thank you again, Avi.
Thank you, Avi. Thank you, Tal, Ilana.
Thank you, Avi.
Thank you, everybody.
Thank you so much.
Bye, Muli, toda.
Bye.
Bye, bye.
Bye.
תודה, תודה, תודה.
Bye, תודה. I also have to go.
Bye, Frauke.
Bye bye.
I also have to leave. Thank you very much.
Bye, Kalman.
Have a
Bye,
nice
guys.
evening.
You too.
It was good to see you, Kalman.
Oh, yes, always good to see you. Bye.
Any questions or just bye? No, I think...
Question?
Yes, hi, Linda.
Hi.
וואו, איך את נראית מעולה. כל הכבוד.
Thank you. So the question that I have is, with my training, we were always taught that if a client patient starts discussing suicide, that our responsibility was to give them the number of the local suicide support center. The information that we got today from Avi is really, really valuable into how to assess, because sometimes people will use the word suicide just to get a little bit more attention. But the charts that we have for evaluation that he gave us, I think are invaluable. But it would be really great to know if there's a suicide prevention hotline in different countries around the world. And I don't know if that's something that somebody would be open to investigating. Right now, I'm investigating as little as possible. I've got a lot going on up here.
At the moment, I think we have only the numbers of Israel in the website, right? And on the file. But yes, I agree.
I think this is part of what we need to enter into the protocol. There is a main suicide line in the US. I'm sure there is one in different states in Europe, and we can just have that.
Yeah, I think that would be really valuable if we do our evaluation and we see that this is a really serious case, to be able to give them.
I want to point out this is a safeguard completely. I mean, but I don't think that beside what Ilana described that we had any other cases in the 2 years.
We had one more.
Okay, so 2 out of the 4.
It was perfect, dealt perfectly. Tal, is it still recording?
Yes, I can stop.
Can we